We have wonderful attendance because I think Dr. Sloan is very well known to many of us. So I get to introduce Dr. Snyder, who will then introduce a Bove lecture, and Dr. Van Doren, who will introduce Dr. Sloan. So Dr. Snyder is actually a professor of laboratory medicine and pathology. He attends at the Yale Blood Bank and is also director of the blood bank at Bridgeport Hospital. He also is a chair of the Yale Provost Conflict of Interest Committee and chair of the Cancer Center membership, and has worked, with the Bove lectureship for a long time. And let's welcome Dr. Snyder.
Thank you. Thank you. It's a pleasure to be here. Joe Bove was the first director of the blood bank here, started in 1959. He was the director until 2016. I was his first fellow. And there's only been 3 directors of this blood bank, Joe, myself, and now Chris Tormey. So it's not a huge lineage. We all tend to have staying power. Joe was a very strong proponent of communications and working with other departments in the hospital. I think he would be very pleased to know that this lectureship, which we set up the day when he retired with the Cancer Center, is still functional and is doing as well as it is. Joe was recruited by Dave Seligson, who was our first chair, and Brian Smith is the 3rd chair of the Department of Lab Medicine, and in between was Peter Jatlow. Joe was a mentor and a tormentor of sorts. He once asked me a question. He says, Snyder, he never called me Ed. He said, Snyder, what's my job here? I said, well, your job is to run the blood bank and provide blood. He went, no. So after 7 or 8 more miserable attempts and haven't come up with the correct answer, he finally gave up and said, no, my job is to plan. And it didn't mean much to me at the time, but as you walk along in his shoes, you realize that really is the job of the director of the blood bank, to plan, to incorporate the Cancer Center programs that are coming up, CAR T and beyond, and gene therapy, the transplant programs, all of that. The blood bank is a beverage distributor to some, but to many others, it's a source of educational and endowment, and that's why we're very grateful that the Cancer Center partners with us to give this lecture. So Joe passed away in 2016, and this lecture is to honor him. And we are very grateful and glad to have as our speaker here, Mark Sloan. So I will introduce Dr. Van Doren, who will introduce the speaker, and then maybe someone will start talking.
Okay, I am so excited for Dr. Sloan to be here. I first met Dr. Sloan in 2016 at a club. It was an ASH fundraiser, so I told him ahead of time I was going to say that. But then again, in 2019, as a senior fellow, when I was on the interview trail and I interviewed at BMC, I didn't end up there, but we kind of stayed in touch since then. And so happy homecoming, Dr. Sloan. He actually graduated from Yale School of Medicine. He did his internal medicine residency here, and then he went on to do fellowship at Dana-Farber, MGH Brigham. And now he's been faculty for quite some time at Boston Medical Center, specializes in both classical and malignant hematology. And he's a member of the Evans Center for Biomedical Research at BMC, where his research has focused on plasma cell disorders, including AL amyloidosis, and more recent, the bringing attention to the Duffy-null antigen status, or what has historically been called as benign ethnic neutropenia, which we have now renamed. He also serves as a fellowship program director and as medical director for sickle cell gene therapy at BMC. And in 2023, he gave a phenomenal talk at ASH that discussed the epidemiology, history, and also research into Duffy-null antigen status and what this means for all of our patients, and not just patients with cancer or blood disorders, but patients in general. So welcome, Dr. Sloan.
Thanks, Leila, and thanks for having me. It's such a pleasure to be here. I just want to first acknowledge that it's really the Yale hematology section that sparked my interest in hematology and sustained it. I want to in particular acknowledge Tom Duffy, who provided me with some of my fondest memories of medical school, sitting in his living room talking about the history of medicine. Joel Rappaport, who took me aside after rounds and talked to me about the good parts and bad parts of academic medicine that weren't always apparent to me at the time. And Nancy Berliner, who continues to remind me that mentorship is a lifelong process. I would also just point out that these people kind of share like a liberal arts approach to hematology, where they're excellent hematologists, but they just know a lot of stuff. And you never know what the future holds. You never really know what you're going to be doing in 5 years. But if you have kind of a good background, then you're prepared for whatever comes around the corner. And this is sort of a good example of that. Someone asked me at dinner last night, how did you become interested in this? And I became an authority on it when I started sending angry tweets out into the void about my experience caring for a woman who had a Duffy-associated neutrophil count on a clinical trial. And my tweet, which was from July 2021, said, I don't know who needs to hear this, swag, but if you write a protocol that requires holding therapy for a low ANC, it makes it impossible to treat Duffy-null, aka benign ethnic neutropenia patients. The result is that Black patients either don't go on trial or are taken off trial. Fix it. And this was the beginning of many years of interest in this that's culminating today. So the outline for my talk is first, I'd just like to explain to you the basis for the Duffy-null phenotype, the epidemiology and the significance of a Duffy-associated neutrophil count. The second part of my talk will be to discuss the many clinical consequences of a Duffy-associated neutrophil count. And then for the third part, I want to offer you all some practical steps that will help minimize the deleterious impact of Duffy-associated neutrophil count on health outcomes. I'll also point out now that we've started calling Duffy-associated neutrophil counts dank. My wife says dank is bad. It's like dank basement. It smells bad. My kids say dank is good, dank memes, dank weed, dank music. So have it what you will, but I think we're stuck with that moving forward. In 1941, someone first published the observation that Black sharecroppers in Mississippi had lower white cell counts than white workers who worked under the same situations. Then in 1950, when working up a transfusion reaction separately, the Duffy antigen was discovered. The Duffy antigen in 1975 was found to be the receptor for Plasmodium vivax, but it was only recently in 2009 that we were able to pin down the association of the Duffy antigen and the Duffy-null phenotype with the phenomenon of what was then known as benign ethnic neutropenia. So this is all a relatively recent development, even though we've known about the phenomenon of lower white cell counts in Black people for a long time. Yep, wrong way. All right. So this is a picture of the Duffy antigen on the red cell. The Duffy antigen receptor for chemokine, DARC, is another name for the Duffy antigen. And it is indeed the binding site for the Plasmodium vivax merozoite. Plasmodium vivax, for anybody not familiar with it, is the less virulent form of malaria, Plasmodium falciparum being the worst one. But the Duffy antigen is also expressed on the endothelium, where it serves a different purpose. It is a decoy receptor, so it's not actually hooked up to anything, but it binds to multiple cytokines. And because of its binding ability, it can serve both as a cytokine sink and a reservoir that modulates the cytokine levels, and it impacts leukocyte trafficking. Because of the profound negative selection pressure to lose the Duffy antigen in settings where Plasmodium vivax exists, you can see that in parts of sub-Saharan Africa, there's almost 100% Duffy-null phenotype. Whereas in the United States, 2/3 of the people in the US who identify as Black will have a Duffy-null phenotype. So the question people ask, and the only complicated part of this talk is you say, well, like, all right, so we're talking about the Duffy antigen on red cells, but then you're going on to talk about the neutrophil count. How does a red cell antigen result in a lower neutrophil count? And the reason it's confusing is nobody really understands it. But there's something about having the Duffy antigen on the endothelium that directs neutrophils. And so neutrophils in Duffy-null individuals have an increased propensity to leave the circulation and will preferentially localize to the marrow and the spleen rather than in the blood. The result of this is that the total body neutrophil count is unchanged, but the localization is altered. This is a recent paper that painstakingly described the distribution of immune cells in tissue. The neutrophils are these kind of bluish cells that you see predominantly in the bone marrow as the second location, but much less. They're in the lymphatic system, particularly the spleen. And then the blood is like the third most common location for neutrophils. But it's important to also acknowledge that not every neutrophil that's in the vascular space is free floating and able to be reflected in your ANC, because many of them are adherent to the endothelium. This is another way of describing the exact same data. You see that neutrophils are by far the most common cell in our immune system, with T cells being a fairly distant second. And the majority of those neutrophils are in the bone marrow. And it's really less than 5% of the neutrophils that are circulating in the blood. And so when you look at the ANC from a CBC with differential, it's important to realize that it's only capturing a very small, less than 5% proportion of the total body neutrophils. And it's an imperfect proxy for the total body neutrophil count, which is what we feel actually matters to prevent bacterial infection. It is indeed the Duffy status that governs the neutrophil count in Black people. Here you see that Duffy non-null Black people, is this showing up? No. Duffy non-null Black people have an ANC with a median of about 5,000, whereas Duffy null Black persons have an ANC with a median of 2,800. With a quarter of them will have an ANC of less than 2,000, and 10% will have an ANC of less than 1,500. So again, for the back, it's not about being Black that gives you a low neutrophil count. It's about being Duffy null, which gives you a low neutrophil count, and Duffy null is more prevalent in Blacks. So when you think about the consequences of this and numbers of this, so 2/3 of Black Americans are Duffy null. That's 27 million Americans. About a quarter of them will have an ANC of less than 2,000. That's 6.6. And about 10% of them will be, frankly, what we call neutropenic, according to standard reference ranges that were mainly comprised of white individuals. So 2.7 million Americans, healthy Americans, will be given a diagnosis of, quote, neutropenia. So if you look at most people's reference range, or most institutions' reference range, it goes between 1,900 and 7,500. That's supposed to encompass 95% of the population. But there's really a truly distinct Duffy null reference range that starts from a much lower value of 1,200 and goes up to 5,400. But because of the distribution, it is possible that an ANC as low as 500 may be normal in some people with a Duffy null phenotype. That's particularly true in children who have lower ANCs in general. And what we don't know is what is the appropriate reference range to use for Duffy null children. We're trying to gather that data. But there's a distinct reference range that should be used for Duffy null adults. That is, of course, reflected in the population of your hospital. So if you go to sub-Saharan Africa, in Togo, for instance, you'll see that the normal ANC reference range goes as low as 500. And in the rest of Africa, it is down into the 900s or thousands. But the important thing to realize is that the Duffy null phenotype is a healthy state. It is not a disease. There's absolutely no evidence that Duffy null patients have an increased risk of infection. This matches with our general clinical experience and is consistent with the physiology of DANK, which shows that the total body neutrophil count is preserved. People with DANK have normal marrow cellularity. they have normal neutrophil function, they have normal neutrophil response to infection, and they have normal neutrophil effector functions. So my conclusions from part one of this talk is that the absence of the Duffy antigen causes lower circulating neutrophil counts. 2/3 of persons identifying as Black in the United States are Duffy-null and will have a Duffy-null associated neutrophil count. DANK is a normal variant without propensity to infection, and a distinct reference range is needed to reflect the ANC count in healthy Duffy-null individuals. Now we'll talk about the clinical consequences of Duffy-associated neutrophil counts. The first is it generates an enormous number of referrals, and I feel like all of my hematology colleagues see these all the time. We reviewed our experience at my hospital, Boston Medical Center. We looked at 103 patients who had been referred for neutropenia between 2020 and 2022, 78 of which completed their initial consultation. I do want to point out that and the early, this is really the time at which we started doing Duffy antigen testing. So the patients that were evaluated in 2020 probably did not have Duffy antigen testing. It was much more likely to occur in the patients in late 2021. But we pulled the demographic data from EPIC's ethnicity and demographics tab. And then we looked at the variables, including the white cell count and ANC at the time of the visit and the nadir within the preceding year, Duffy testing if it was performed, any other laboratory testing done at the time of the consultation, what the ultimate diagnosis given was, and the number of follow-up visits needed. What we found is that the majority of our neutropenia referrals were Black, 67%, and that every Black patient who was referred for neutropenia where we did Duffy testing did turn out to be Duffy-null. The Duffy-null patients had lower overall cost of visit, and it was significant, $360 versus $738, and were less likely to require follow-up appointments. And so I think our conclusion from this study is that hematologists are easily able to predict who will have a Duffy-null associated neutropenia based upon the review of the CBC with differential, the patient demographics, which include age and race, and the comorbidities, especially what other medications they're on. So these neutropenia referrals can be actually intercepted upon the time of initial review, and seeing the patient adds very, very little to it. And so we've changed our referral system to try to empower the referring provider to help make this diagnosis rather than dragging people into clinic. Another conclusion is that testing for Duffy status prevented additional, more expensive testing and unnecessary follow-up. In other words, if you see a patient for what's considered to be a low ANC and you test them for Duffy and they're Duffy-null, then that's it. You don't also send an ANA, and you don't also send a flow cytometry to rule out LGL leukemia. This improves both access and cost containment. We would like to normalize the concept that people should know both their ABO type and their Duffy status. So when this issue comes up in the future, they can just point out to whoever is discussing their white count with them that oh, I'm Duffy-null and I know that, and that's expected for me. We also wanted to empower primary care providers to recognize isolated lower neutrophils in a healthy patient with Duffy-null phenotype as normal, with the goal of reducing the volume of referrals for uncomplicated Duffy-null individuals, which will assist in cost containment and improve access. The next and more important issue is barriers that our patients are experiencing as they try to obtain appropriate care for other diseases. So the problem is that drugs are often discontinued in Duffy-null persons for leukopenia without any clinical toxicity. And so there are studies showing that Duffy-null patients had higher azathioprine discontinuation than other genotypes. That's important for rheumatologic disease. We also have data that suggests that it contributes to higher rates of chronic graft rejection in kidney transplant recipients from inappropriately low azathioprine dosing. It was also found that African-American patients with schizophrenia were discontinued from clozapine at higher rates than whites, even though they did not have any increased complications. These are just two examples, but any medicine that's even slightly myelosuppressive is going to encounter a similar problem in Duffy-null individuals. What I'd like to spend the rest or the majority of the rest of my talk focusing on is what I feel is the most urgent issue, which is clinical trial eligibility and dose modification. It's not news to you that generally Black people do worse with cancer than white people. This information has been taken from Black women with breast cancer treatment, but there's similar data for nearly every type of cancer. Black women took longer than white women to complete adjuvant chemotherapy treatment for breast cancer. Black race is associated with early termination of chemotherapy and poorer survival in early stage breast cancer. And even when they're treated on a protocol that specifies when drugs are to be held and dose reduced, patients on the SWOG adjuvant breast cancer studies, if they were Black, were more likely to experience early discontinuation or treatment delay. And one of the most powerful predictors of a relative dose intensity of less than 85%, which we think of as being critical in the curative cancers, such as adjuvant treatment of breast cancer or aggressive lymphoma, is that low white blood cell count predicts their dose intensity. Low baseline white blood cell count predicts their intensity. Together with some colleagues, we reviewed nearly 400 phase 3 trials that were open between 2021 and 2023 to see what their eligibility criteria were and whether they were at risk for excluding people with Duffy-null status who had ANCs within the expected reference range for a Duffy-null individual. We included both explicit exclusions. In other words, you need an ANC of over 1,500 to get into a trial. That's an explicit exclusion, or implicit exclusions, which would say that ANC range needs to be normal. And if your ANC range at your hospital didn't have a separate Duffy-null range, then you would also be excluded. And what we found was that 3/4 of trials were at risk of excluding patients with a normal ANC. And it didn't really make much of a difference whether we're talking about cytotoxic chemotherapy or targeted chemotherapy alone. So this in and of itself is a problem. We are not letting Duffy-null individuals onto clinical trials, which means that we're excluding a lot of Black patients from our clinical trials. But you'd think this is kind of easy to fix. It's not as easy to fix as you'd think. People are resistant to it. But just fixing the inclusion-exclusion criteria alone is not enough. And the reason it's not enough is because if you let somebody in with a lowish ANC onto your clinical trial and then you give them an even slightly myelosuppressive medicine, they're going to start encountering mandatory dose holds and dose reductions. And so our next step was to look at dose modifications required by clinical trials. And what we saw was that half of them required dose modifications for ANC within the Duffy-null reference range. And this is even worse than it sounds because this is even before they have any effect of the treatments. This is just for existing. Many Black patients are needing a dose reduction as a part of the clinical trial. So excluding hormone therapies, modifications were present in 69% of the studies. And this impacted not just the experimental arms, but also the standard of care arms. So everybody on the study was affected, even if you were just trying to get standard of care. And it's because of this reason that investigators like myself were reluctant to enroll DANK patients on studies that mandate dose reductions for ANCs within the normal Duffy-null phenotype. But it's not just limited to clinical trial, because those dose modification tables in the clinical trials eventually become the FDA labels, and they impact everyone. They impact how we modify these doses for anybody getting these treatments. And so if you look at the dose modification in the FDA labels for the medicines approved over the past several years, you see that nearly 90% of the medicines approved for lung cancer will either implicitly or explicitly require dose modification just for being Duffy-null. I want to take you through an illustrative example. This is what prompted that initial tweet, which was the SWOG 1803 study, which is a study for patients who had multiple myeloma that received a transplant and then were randomized to either lenalidomide, which is the standard of care after transplant, or lenalidomide and daratumumab, which was the experimental arm. One of my patients had an ANC of 1,500 and was eligible for the study and went on the study, was randomized to the standard of care arm, which was just lenalidomide. And then her ANC went down from 1,500 to 900, which is kind of expected for that medication. If they weren't on the clinical trial, we would have just continued her at that dose of lenalidomide. But because she was on the clinical trial and the ANC of 900 counted as a grade 3 neutropenia, the protocol mandated that we hold her lenalidomide, that we check weekly CBCs, that we consider GCSF therapy, and then when it was restarted, it needed to be restarted at a lower dose. And this is completely inappropriate. What we campaigned for and took a long time to get, but we had them modify the trial to include a Duffy-null specific dose modification table that allowed much more lenient dose modifications for ANC. And because of this change, we were able to start enrolling patients again, and it made a big difference in the number of Black patients on this trial. I'll also point out that this wasn't easy to accomplish. There's a number of people that were really reluctant to do this. Everyone's scared of febrile neutropenia. Everyone thinks that everyone else needs to sign off on it. But once someone decides that this is the right thing to do, it's incredibly easy to stick an additional table in your protocol. So it took a long time to get people to agree to do that, but it was very fast. I know that a lot of you have investigator-initiated trials, and I'll just point out that you can either include a separate Duffy-null table, or you can just put a footnote in your protocol that say that for patients with known Duffy-null phenotype, a lower neutrophil count may be used for dose reductions, and that would cover you. So very easy to do. Please consider putting this in your investigator-initiated trials. The point being that Duffy-specific dose modification is very possible. This is my most important slide. And we mentioned and touched upon some of the data that the outcomes of Black patients with cancer are generally inferior to whites. And we all know that Duffy negativity may be a surrogate for other adverse markers, including socioeconomic ones. And those socioeconomic change problems are hard to fix. But the question that haunts me, the question that I would like you to ask yourself when you see these patients is how much of the disparities that we see in Black patients are simply due to inappropriate dose intensity in Duffy-null persons. We know that dosing matters. We know that dose intensity matters. And this is a fixable problem. We know about it. We know how to fix it. And this has the potential to get rid of at least a proportion of the disparities that we're seeing. I'm about to describe why I believe that the situation is about to get worse in an era of targeted therapy, but I really want you guys to consider how much of the cancer disparities outcome we're seeing is just due to this problem. My conclusions from part 2 of this talk is that considering a normal Duffy-null associated neutrophil count to be pathologically low causes many potential adverse outcomes. The preclusion from indicated medicines and barriers to procedures, exclusions from clinical trials, and inappropriate dose reductions. More generally, I need you guys to rethink the significance of neutropenia in a modern era. So I went through and I've pulled out several of large phase 3 clinical trials of targeted therapy in myeloma, breast cancer, CLL, and follicular lymphoma. And these trials were almost overwhelmingly using white patients. So this problem is going to be even worse in Duffy-null individuals or trials that included Black patients. And what you see is really, really high rates of grade 3 or 4 neutropenia in these targeted therapy situations. So 50% in the case of lenalidomide maintenance, almost 2/3 in the case of palbociclib. But despite these very high rates of grade 3 or 4 neutropenia, we are seeing really low febrile neutropenia, often in keeping with the comparator arm which in some cases was placebo. So the theme here is that despite the high rates of grade 3 or 4 neutropenia, rates of febrile neutropenia remain low in most targeted therapy situations. I'm going to bring you in for a closer look in a recent trial. This looked at CLL and fixed duration acalabrutinib combinations. And so here, let me see if I can get my mouse. So this is the adverse event table from that trial, from the supplement of that trial. We have 2 targeted therapy combinations, acalabrutinib and venetoclax in the leftmost column, acalabrutinib, venetoclax, and obinutuzumab in the middle column. And then the third arm was actually chemotherapy, so fludarabine, cetuximab, rituximab, or bendamustine, rituximab. And what you see is high rates, oops, I can highlight this, high rates of high-grade neutropenia across arms. So 26% in the AV arm, 35% in the AVO arm, and 32% in the chemotherapy arm. So despite these nearly identical rates of grade 3 or 4 neutropenia, the rates of febrile neutropenia were very low in the targeted therapy arm, 1.7% and 2.5%, and much higher in the chemotherapy arm. You need to think about why this is, because if you, really in continuous targeted therapy, the neutrophil count will go down and stay down. So the total time in the neutropenic window is much higher in the targeted therapy situation than the cyclic cytotoxic chemotherapy situation where it goes down, touches bottom, and comes back up. So we need to consider why this is. And I think that the obvious reason is that febrile neutropenia is not really driven by ANC alone. It is a lot of the non-medullary toxicities of chemotherapy, such as mucositis and diarrhea, that are driving the febrile neutropenia risk. Or perhaps it's due to the kinetics of the neutropenia, that there's something particularly harmful about an abrupt drop in neutrophil count that predisposes people to infection. The bottom line here is that you should be very wary of dose reductions for low ANC in patients on targeted therapy. And this is going to be a particular problem in Duffy-null individuals. There's a cleaner way to fix this. The common terminology criteria for adverse events, the CTCAE, creates a toxicity grading system for every adverse event that you can encounter. And most protocols, most clinical trials will specify that, oh, if you have a grade 3 toxicity, you need to hold your drug and then reintroduce it at a lower dose. So if we could change the CTCAE criteria or create a Duffy-null specific CTCAE criteria, we wouldn't have to include individual protocol modifications. And so the top level is what the CTCAE says it is now, that you have a grade 1 neutropenia if you're between the lower level of normal at your institution and 1,500. Grade 2 is 1,000 to 1,500. Grade 3, 1,000 to 500. And grade 4 is less than 500. There really needs to be a Duffy-null specific modification. Grade 1 neutropenia with or without Duffy-null is not clinically significant. We feel like we should just get rid of it. So we get rid of grade 1, and then we would lower the thresholds for grade 2, 3, and 4. We can argue about the exact numbers that we should lower them to. It's a touchy subject, but I think the principle is that we clearly need this modification to CTCAE to happen. The question that people ask me, and fairly, is well, how low is too low, right? Like when do you get uncomfortable treating somebody who has a Duffy-associated neutropenia with a medicine that's making the neutrophil count go down any longer? So let's look at the evidence around that. The first study I'd like to review is what's called the Polina study of palbociclib. Palbociclib is a CDK inhibitor for breast cancer, notorious for causing neutropenia. And there weren't a lot of American women in the initial trial of palbociclib. So Lindsay all set out to see if they could give this medication to African-American women, and they typed them all by Duffy status. But they were still held to the FDA label, and so dose reductions were still mandated when people got to a grade 3 neutropenia. So what they found was that Duffy-null women had more grade 3 or 4 neutropenias, 72% versus 23%. That more Duffy-null patients required dose reductions, 55% versus 8%. Duffy-null patients had lower overall dose intensity and lower clinical benefit, and that there were no episodes of febrile neutropenia on this trial. So what that means is that just following the label isn't enough. We need to make changes, but again, it's not the low ANC that doesn't necessarily correlate to more infectious complications. At my hospital, we looked at 136 patients who had myeloma who were getting treatment with immunomodulatory agents, mostly lenalidomide. What we found was that Duffy-null patients had more treatment-related neutropenia. We did not see more treatment interruptions or dose reductions between the groups. In part is because we're quite proactive about testing everybody. So we know who's Duffy-null and who's not. And as a group, we've decided to try to minimize dose reductions in asymptomatic Duffy-null individuals. And that's why we're able to not see that difference. If you look at it, you looked at the results, Duffy-null patients actually had less episodes of febrile neutropenia than Duffy-null, non-null individuals. More recently, we evaluated the effect of Duffy status on patients with breast cancer receiving CDK inhibitors, such as palbociclib at my hospital. We reviewed 71 patients. 30% of the patients typed as Duffy-null, 54% were Duffy non-null. We couldn't get typing in quite everybody, so 17% is unknown. The Duffy-null patients had lower pre- and post-treatment white blood cell counts and ANCs, as one might expect. Many of those patients were driven into a grade 3 or 4 neutropenic state, but no patient with grade 3 or 4 neutropenia was hospitalized for fever, suggesting that these patients tolerate neutropenia very well. So to summarize these past few slides, neutropenia does not equate with complications in Duffy-null individuals, and there should be no difference in rates of dose reductions by Duffy status. So we can argue about the number, but in general, if you're only reducing 10% of white people, then you should only be reducing 10% of Duffy-null people. So here is the way forward, all right? First, we need to kind of use correct terminology, and Dr. Van Doorn mentioned that we, for a long time, used the phrase benign ethnic neutropenia, and the definition for that was that an ANC of less than 1,500 without any signs or symptoms of infections in those of African or Middle Eastern descent. The problem with that is that when you call it ethnicity, that's a social or cultural identity, and when you call it neutropenia, that implies that it's a pathologic state. So we're trying to move away from this. And the preferred phrase is now Duffy-null associated neutrophil count, which gives it its biologic association with the Duffy antigen. And instead of calling it neutropenia, we call it just neutrophil count, which implies that this is a normal, healthy state for these people. All the blood bankers and pathology residents know this. It's the Duffy testing itself is very straightforward. You can either do genotyping, which is somewhat complicated and expensive, or you can just do red cell phenotyping, which is available at any blood bank. And all you need to do is test for the presence of the Duffy antigen using serologic reagents. Of course, you need to be negative for Duffy A and Duffy B to be considered Duffy null. But this is a straightforward, low-cost test. At our hospital, it costs exactly as much as a type-in screen, which is on the order of $300. So, but the problem is that clinicians are having trouble accessing the order to this test. I was pleased talking to Dr. Tormey last night that Yale has addressed this problem, as we did, is we made a Duffy test easy to order and easy to interpret. All you need to do is type into Epic Duffy, and this test for Duffy antigen screening comes up. It's very straightforward. And then when the test results, it's not buried under a blood bank tab as FY A minus, B minus. It has a very clear negative for Duffy A and Duffy B antigen with an interpretive statement that our hospital says if both Duffy antigens are negative, then this patient has a Duffy null phenotype and is expected to have lower circulating neutrophils, also referred to as Duffy null associated neutrophil count. This lower ANC does not correlate with increased risk of infection and should not be a barrier to receiving appropriate medications or procedures. If either Duffy antigen is positive, then this patient expresses the Duffy antigen and is not expected to have dengue. Simply implementing this order greatly increased the testing performed at our hospital. Over the 6 months that we implemented the order, Duffy antigen screening testing doubled. The next path forward, and I think you guys are working on this but aren't quite there yet, is that you need to validate and use the published reference range for adults in Duffy-null patients at your institution. So what we have here along the bottom is we give the standard ANC reference range, which is 1.92 to 7.6. And then immediately below that, we write a comment that says 1.21 to 5.95 is the reference range for individuals with a Duffy-null phenotype, and that if it's appropriate, Duffy antigen screening can be ordered to determine Duffy-null status. This sounds like a really difficult thing to do, but the truth is it really only requires 20 Duffy-null samples to validate an existing reference range. So this can be not a trivial matter, but it can be a very straightforward thing to get validation. Kids is a different story, but we're working on that. Other things that you can do now that will make a difference is to advocate for appropriate medical care in Duffy-null individuals despite a low ANC. You need to be wary of exclusions or dose reductions for neutropenia, especially in Duffy-null patients, and that you should really be testing for Duffy status prior to starting no myelosuppressive medications to set expectations and know when a lowish ANC is okay and you should push through. Also, as mentioned, we want to normalize patients knowing both their ABO type and their Duffy status to empower them in the future as well. Things that you can do now in the clinical trial setting, we mentioned including Duffy-null specific inclusion criteria in your investigator-initiated trials and Duffy-null specific dose modification tables. When you have somebody on a pharma-sponsored study that is encountering what you feel is like an inappropriate dose modification, rather than just implementing it, please reach out to the medical monitor and communicate with them that you have a Duffy-null patient. You do not feel like this is an appropriate dose reduction. And sometimes they will listen to you and sometimes not. But we need to start that conversation with our pharma colleagues. And first, and I would also say that pharma has been very reluctant to change, in part because febrile neutropenia is a feared complication of all their trials, but they cannot open trials without us. And so at some point, we might need to take the matter into our own hands and just consider refusing to open a trial that does not include fair representation of Duffy-null patients. My final conclusion slide is just to review that 2/3 of Black people in the United States have a Duffy-null associated neutrophil count, that dengue is not a disease, that there are serious downstream consequences of dengue, and that there are straightforward fixes to this problem that don't compromise patient safety. Really enormously grateful to my colleagues, particularly in the pathology and blood bank, who have collaborated with me to get some of these things up and running. Also the number of medical students, residents, and fellows that have helped analyze data. And my colleagues, particularly Lauren Mers at Dana-Farber, who's been very active with the space and lent me some of her slides. Is really exciting to see how quickly things are changing for the better. Thank you.
Dr. Krish?
Oh, that was fabulous. Great work. A couple of questions for you. How well do they mobilize?
That's a great question, and we have an answer to that question, is that Duffy-null individuals mobilize normally.
I have a question. It seems like we should lower dose or decrease dose reductions for all patients.
Yes.
And then we would already fix it for a lot of people. And maybe your research could kind of lead in that direction.
Yeah. Yeah. So I think for continuous targeted therapy, dose reducing for an ANC of 1200 is not the correct thing to do for anybody, and will allow us to give higher, more effective doses of our medicines. And I think you're right. That needs to change in general, but we're just seeing it more acutely in Duffy-null individuals.
Hi, thank you for your talk. You mentioned there's no increased incidence of infections or anything, but are there any functional consequences of being Duffy-null, especially since you mentioned it's like a chemokine reservoir? Anything to do with the autoimmune or inflammatory diseases?
That is a great question that we don't have a great answer for. There are some treatments, particularly in the myeloma space, that seem to work better or worse in Black people. And it's not clear why that is. What is needed is a large group of Black persons, and then we can separate outcomes into Duffy-null and Duffy non-null Black persons, which would control for a lot of the socioeconomic problems that we're seeing, to figure out whether Duffy-null is responsible for it. But that is a distinct possibility. We just don't have a good answer for it.
But is it understood why or how that Duffy antigen is affecting the ability of cells to extravasate? Might it affect cells other than polyps?
Yeah. So the question for anybody online was the question I was dreading, which is, how does it actually work? And I think that the short answer is that nobody really knows that. It might have to do with the interaction of neutrophils with the Duffy antigen in the bone marrow as they're differentiating, that those neutrophils have a characteristic. Or it might just simply have to do with the Duffy antigen on the endothelium, but it's not well worked out. A lot of room for figuring that out if you're interested.
We have an award to give you, but it's so wonderful to have so many trainees in the audience. So do you have like some suggestions? Trainees always look for research projects. Any suggestions what, trainees in the audience should research and think about?
Yeah. So I don't know. I've done a fair bit of clinical research, and this has been the most painless clinical research that I've ever done. In part because it was new and nobody else was working on it. In part because I work at a hospital that has a good clinical research infrastructure and a lot of Black patients, and so it's become incredibly easy to study renal transplant outcomes or rheumatoid arthritis outcomes. I kind of feel like you should never do a project alone if people are willing to help you, and so I've always welcomed med students and residents and fellows. But the other point I think is that, like, if you had asked me 5 years ago if I would be interested in the space, I would say I don't know anything about it, and so it's just about kind of being open to new ideas and being able to pivot has been really helpful and fruitful in my life. It's not necessarily the path to academic superstardom, but I really enjoyed it.
Hi, thank you, Dr. Sloan, for that excellent talk. I have one question. With someone who has a known like DANK status, when do you I guess, what level of variation should be kind of expected in terms of when the counts kind of fluctuate? And I guess, and at what point should you be concerned about, there being like another underlying reason for, like, say, lowering neutrophil counts without them being on, say, like cytotoxic therapy?
Yeah. So there's kind of two questions in there. One is how low is too low, which is a complicated question because everyone's going to get nervous if you have an ANC of 300 and you're keeping someone on full strength treatment. And we don't have a great answer for that yet. The other question is, well, when do you need to work up somebody for other causes of neutropenia when they have a known Duffy-null status? And I think that just has to do with clinical suspicion. If you have a healthy, young Black person, and that person doesn't need a lot of additional workup. Whereas if you have somebody that is more likely to have, say, an LGL leukemia because they're older and they have, a rheumatologic condition, then you probably should do it in that circumstance. So don't blow off neutropenia in Duffy-null individuals, but you just need to know what to expect is normal. Yes, Christian. We would tolerate, I don't know if you thought about. Yeah. No, I agree. And I'll also point out an idiosyncrasy, even amongst adult oncologists, that hematologists have very different tolerance for neutropenia than oncologists do. So for Hodgkin lymphoma, where you're giving chemotherapy every 2 weeks and the ANC never has that third week to fully recover, we're very tolerant of low ANCs, and there's certain things that we look for to reassure ourselves, like the monocyte count is up, that the marrow is coming back, and we'll move forward. But despite being neutropenic for essentially 6 months, the rate of febrile neutropenia in Hodgkin lymphoma is very low, right? Whereas kind of our lung cancer colleagues are much more nervous about it. So there's a lot of variability, with hematologists generally being more understanding of these things.
One question, how prevalent is the understanding of this situation among oncologists nationwide treating people who aren't involved in large clinical trials or in smaller hospitals around the country? Is this a big problem, do you think?
Yeah. I would say that most people don't know about it, and it's fun to explain it because people can actually understand it. It's not rocket science, but people are very interested. Everyone wants to do the right thing, but a lot of people don't know about it. And I just also want to point out that this isn't just an oncologic problem, that we need to be talking to our psychiatrists who does clozapine. We need to be talking to our rheumatologists. We need to be talking to our transplant surgeons. So everybody kind of needs to know about this and understand it.
I was wondering how you talk to patients about it and provide reassurance. And you mentioned potentially empowering them to know their Duffy-null status moving forward, so they avoid unnecessary consults and workup.
Yeah. So that's a good question, and it goes differently for different people. I will point out that ASH very recently does have some patient education material on this topic that you can print out and provide to people, so they make you seem more authoritative if there's something to give to people. I just explained that God made everybody differently, and 2/3 of Black people have a lower normal neutrophil count, and it's not a disease, and most people are accepting of that. Some people still eye you with suspicion.
I have a question.
Yeah.
Should everyone who has neutropenia in the right clinical context be tested, and who should be testing them? Would it be care? And then, well, those are my questions.
Okay. Great question. So we're advocating for universal testing in clinical trial settings. Obviously, you're going to be screening a bunch of white people who are very, very unlikely to be Duffy-null. But it gets dicey if you're guessing who is at risk for being Duffy-null. So in the clinical trial situations, we are encouraging companies to universally screen for Duffy-null. At my hospital, which is about 50% Black, we have it with our initial chemotherapy orders. You get tested for HIV, you get tested for Duffy, and then any other drug-specific testing. And it's just kind of, it's been a good way of generating data, but it's really important that people know who's Duffy null when they go to dose chemotherapy. And I would really encourage you guys to consider that, or at least make a checkbox in your EPIC protocols so that you can consider, like, is this person at risk for being Duffy null or not? Right behind you, Layla.
This might be a silly question, but why aren't we just incorporating Duffy null testing into type and screen since it's the same type of assay?
That's a good question. Dr. Snyder?
Well, I mean, you could do that. The reagents are not inexpensive, but certainly we test for ABO and we test for RH. We don't test for the other 14 or so clinically relevant antigens. You could make a case for this. We could certainly discuss it with our overlords to see if the finances are there. But it's doable. It's just a question of probably be better to do it selectively. But then again, you start profiling, it gets sticky very quickly. So I'll give that to Chris Tormey to answer you.
I think it's a great
about
question.
it at Bridgeport.
I think
Thank
the
you for
other
bringing it
thing that you have to remember also, Dr. Sloan, is you practice in Massachusetts, right? Where there's universal health care, where when I lived and worked, I didn't see a healthcare bill at all. But here it's different, right?
Yep.
So the lab can bill for the difference. The pathologist who reads the Duffy null testing can bill as well. So it could be almost $500 just for someone to have Duffy null testing.
That's a fair observation that I don't have a great counter argument to, but I will say that there is an ICD-9 code for Duffy null status now, so it does lead to a diagnosis which should be reimbursable. Okay.